So Lenny Macrina, welcome to Torn. First 1 and 2 parts of these series is kind of talking about what the ACL is and how it's torn. And then speaking with a surgeon, we talked about what the ACL reconstruction looks like. And now kind of that third part of the series, I want to talk about the rehab process and kind of, no one better to do it than a renowned physical therapist like yourself and someone who's been around the ACL quite often. So welcome to Torn. I appreciate you coming on.
Yeah, thank you. We love ACLs. It's an unfortunate event in somebody's life, and unfortunately, this is how I meet people is when they get hurt, and that's always a difficult conversation. So if they're in my life, it's usually not a good situation, but we try to make the best of it, and it's a long road, and we are with them throughout the way. And it oftentimes turns out to be a positive experience for everybody. So yeah.
So do me a favor, talk a little bit about your background with it, how long you've been in physical therapy, what got you interested in treating the ACLs in general?
Yeah, I've been a PT. I graduated from Boston University in January of 2003. I passed the boards in December of 2002. So I'm approaching my 22nd year as a physical therapist, if my math is correct. And I started working in North Carolina for a year or so, and then moved to Birmingham, Alabama in 2004, and working down there with Dr. Andrews and Kevin Wilk and Mike Reynolds, who's my current business partner. It is just inundated with surgical people, knees, shoulders, elbows, and my schedule's busy. I think new grads or early career professionals now would vomit if they knew what I had to treat during back then, but it was such an amazing experience where I got to see all these patients, volumes of patients, and publish research with ASMI, Dr. Glenn Fleissig, and speak and educate others. And it vaulted my career beyond what I could have expected. And it's just taken off since coming to Boston, having good relationships with surgeons in the area at Champion Physical Therapy and Performance that Mike and I started 10 years ago. Mm-hmm. And my schedule is now basically ACLs and Tommy Johns I sprinkle in some random stuff every once in a while, but it's, it's a lot of ACLs. So I have opinions.
Yeah, absolutely. Well, let's get started with this. So I kind of want to talk about sequentially what it's like coming right out of surgery and then all the way through kind of the return to sport timeline.
Yeah.
So let's start with something basic here. So let's say, you have an ACL come across your caseload. Ideally, you'd like to, maybe have worked with that patient pre-op or even know the surgeon that you're working with and maybe have spoken to them. But let's say you even have a student who is seeing this athlete for the first time post-op. Talk me through, before you even see the athlete, the importance of, the preparation and seeing, okay, is it an ACL? Is it an ACL with a secondary pathology? Kind of talk me through that just so when you go into meeting that athlete for the first time and maybe they're with their parents, what that conversation is going to look like and what the preparation has to go into that.
Yeah, I've got that situation going right now, actually. We just had a kid who we saw pre-op. Most of the doctors that I work with are big into prehab, so I get to see people ahead of surgery and we're able to walk people through their questions. But I do have a patient that just literally had surgery last week, and we started seeing him end of last week. And I think the big thing right now is look at the big picture. I've already been able to speak to that athlete because I saw him before the surgery and talked to him about graft choice, timelines to return, and then the patient comes in after surgery and now it's all beginning to make sense, but it's still a jumbled mess because they haven't been able to live it. And so for the student, my goals are, all right, let's make sure the wounds look good. Like that knee's been wrapped up probably for a few days at least, or they're taking care of it on their own, the patient and the family. So who knows what they're doing with it. I got a interesting story about that if I can remember to say it in a few minutes. Sure. So we're looking at wounds. We're looking at swelling. This person came in, big old swollen knee, and his knee was lacking, excuse my fingernail. I dropped a 45-pound dumbbell, just saw that. It's funny for those watching in the video. But he came in with a big swollen knee and lacking 22 degrees of knee extension, and his other knee hyperextends by about 4 degrees. So he's lacking 26 degrees of symmetry. And I'm like, dude, you sleeping with a pillow under your knee or something? He's like, yeah, I am. It's so comfortable. I'm like, oh my God, we have to stop that. And so it was not a fun week for him to regain that motion, but we got him down to 0 within a few days. But actually yesterday I saw him and he was 0. So we're looking at swelling. We're looking at knee extension. We're looking at overall how he's doing. How is he how's he feeling overall? Is he sleeping okay? Is he eating? Is he pooping? Right? We don't want them to get, because they're on pain meds, we don't want them to get all bound up. And then we begin some easy bending. And the bending is fearful at the beginning, but it seems to, as we gain confidence in the person gains confidence in us, things slowly happen in a positive fashion. And then we begin some stim on their quads. I use the Continuum 2 unit from Chattanooga. And we're just getting some volitional quad contraction with the stim, and we're just pounding quads after that. So that's kind of day one, is look at swelling, look at the person overall, answer their questions, the family, look at wounds, and then begin some easy motion. So that wound story, that I had a person, this was years ago when I was in Birmingham, Alabama, and they were all proud. They were cleaning their knee was nice and clean. I'm like, oh, how often are you cleaning it? Like, something doesn't look right here. He's like, oh, like multiple times a day I'm using hydrogen peroxide. And it turns out, you don't clean it with pure hydrogen peroxide, right? It just kills any tissue that's trying to grow. So back when I was in Birmingham, we used to take stitches out, and I took the stitches out of his knee. And if you know a patella tendon graft, it's maybe an inch and a half long, whatever it is, 2 inches. And the whole wound just opened up because all good tissue was taken away. I was like, they could basically see into his knee. I had to call the docs. They had to go in and put him on, do a local anesthetic and sew him back up, and he had another week or two of stitches. But so make sure you clean your wounds with the appropriate, a diluted peroxide, or just like a little, soap and water around the edges. But that's my story about wound. But so it's just looking at the big picture that first day. I think you're just trying to build a relationship with the person, right? They're in shock. The family's in shock. Like, what did they just go through? And just build a relationship and confidence that the next, 6+ months, 9+ months is going to be a positive experience, even though it doesn't feel like it.
Yeah, I think that first maybe 1 or 2, sessions with that athlete, especially, if they're a younger athlete and their parents are involved in this, is kind of setting the standard a little bit with, like you said, confidence. I think is so important, because 15, 16-year-old, 14-year-old, whatever it might be, the parents are also involved a lot with this too. And the confidence they have in their therapist is very important. So I think standard as far as timeline wise, what this looks like today, certain milestones that you hit throughout, and kind of making sure that precedence is set. Because I will say this too is, in surgery and post surgery, the athlete and the parent might not remember everything that the surgeon said. So a lot of that comes from the reiteration that the physical therapist has, ideally pre-op, because I think that sets a really good standard. Definitely post-op if you haven't seen them before.
And in my practice, we have a little unique situation. We're cash-based. And so it's almost like concierge. So parents and the patient get my cell phone. If they haven't gotten it pre-surgery, they get it that first visit. And then they can text me. I don't care. I'm there for them. I'll answer back on a weekend when I can. And it's usually pretty quickly. Is this normal? Is this pain normal? Can we do this? Can we do that? And I want to be there for them, and that's just, I don't know. It's just, if I was in that situation, I'd want that service as well. I'd want to have somebody that I trusted and can answer questions as needed. So they have my cell, and it's just that relationship just grows, and it leads to, future patients for me that they will refer, and it's just a positive experience for everybody overall. So highly recommend it. Yeah.
What's ideal timeline post-op that you like to see your athletes?
When I was going back to my days in Alabama, we saw them the next day. So post-op day 1, and now in Boston, things have slowed down with the surgeons, and I think just docs in general. I think they're just trying to save visits because of insurance, even though that's not my world. I'm not in the insurance world.
Sure.
So I like to see people 3 to 5 days at the latest. Some doctors are a week. That's fine. That week is a long week for that patient to not know what to do. So fortunately, if I saw them prehab, they have access to me and they can text me, hey, is this normal? Because they are clueless. How do ice, when to ice, how frequently to ice, is the pain normal, is the infection, is the knee looking good, is there an infection, is the swelling normal, can I put weight on it? There's so many different variables and they're like you said earlier, they've gotten instructions from the hospital, but you're not going to remember it all. Like, that kid definitely was told, don't put anything under your knee.
Sure.
And the family completely missed that and created this huge extension loss in the knee. They were definitely told that in the hospital. to not do that when they still didn't remember it. And so I think that those first few days, even if it's basic stuff, you're there to look at wounds, you're there to answer questions, you're there to initiate some motion and just give instruction. I think that's a huge aspect that is kind of lost because we're trying to save visits for down the road. But those first couple of weeks can really
set the standard.
Set the standard and put us ahead of the game. Yeah, definitely.
Yeah. Talk me through a little bit about the importance of extension. So, post-op, obviously, pre-op first and foremost is, I think one of the biggest conversations I have with my athletes is extension post-op. Yeah. And, even just kind of reiterating on pre-op visits, I think the importance of that is more educational than anything else. It's hard to really, unless someone has a huge range of motion loss, to really get them back to the point where obviously it's appropriate enough for surgery. Right. There's not a ton you can maybe do within a few weeks with quad and maybe activate it a little bit. But I think the educational side of it pre-op can be the most helpful, because then they understand, all right, I need to get this thing straight post-op.
I got a kid right now going through
that a little bit.
Yeah, I got a kid. He's having surgery end of October, going through prehab right now. He had an extension loss, and we got it all back. His knee is ready right now. Like, he could have surgery now. I think it's a scheduling issue.
Sure.
But I have them go through it, because oftentimes they are kind of gimpy, and they have some swelling in the knee, and they're fearful. This kid went from fearful, walking in with a 10-degree loss of extension, to now, I don't think I need the surgery. Can I avoid the surgery? That's a different conversation, whether or not he could live without an ACL and play his junior year of football. I'd recommend surgery, and we are doing surgery, but he feels that good that, he could do stuff. And I'm like, dude, let's just, we got your knee to calm down. Yep. Let's get to end of October for the surgery. But he's squatting, he's deadlifting, he's doing stuff. It's not like we're doing leg raises. He's doing stuff, and he's maintaining his motion, and his swelling is not getting worse. So yes, we could have a conversation of coping and non-copers and try to get him through that. But he's 17 years old. I don't know if I feel comfortable with that. And I know there are people that have survived without an ACL, and probably 25 or 30% could probably get away with it. But I don't know if I'm into that just right now in the younger population like that. If it was 40-year-old, then maybe. But yeah, prehab, and I'm doing stuff, and I'm taking videos. I'm texting them a video of what we did, so they have a reminder of how to work on extension, what we did for some exercises, what we did to get his knee to calm down. And I'm sending reminders, hey, you're working on your stuff right now. Like, I harass my patients essentially into doing stuff. I got a girl right now who's going to college down in Trinity in Connecticut, and I'm always checking on her because she has a propensity to lose extension. And so I'm like, hey, you working on your extension? How's your extension? And I'll probably get a text her when I get off this podcast to check on her. It's just, you care about these people, and you care about their outcomes, and I want them the best. Their N equals 1. They don't know. They don't know anything about how to do ACL rehab. They just think it is what it is. And I am guiding it and helping them and giving them advice, and then they have to put into practice.
Yeah, I always say to my athletes, you're one I don't lose sleep over. Right. Extension to me is, one of those things that I leave work thinking it stays with me. So that I agree with you on that one.
It's critical. And I know it seems like a simple concept, but it is critical. And some people are in the world of, you just need 0 degrees. You just need a straight knee. And that is so not true. You need symmetry, but you need symmetry eventually. Comparing it to the other knee, and hopefully the other knee is not an ACL knee, because a lot of the patients I see are, and hopefully they got their normal motion back after that other knee. But you need symmetry. Shelbourne has papers that show that if they lose a few degrees, it can be a negative effect on their knee. They're never going to feel right. The quads are not going to come back to normal. It's just not going to be a good situation for them. So the person that's hyperlaxed like that, 5 of all the Beighton scores, they're positive for all that, or they have 10 degrees of hyperextension on the other knee. Get it back, but get it back slowly. It's not going to be a struggle to get back their extension unless they have a big old cyclops lesion in their knee. But get it back, maybe get 3, 4, 5 degrees at the most early on, and then just let it sit there, and eventually their normal function will get them down to 10. If they're like that typical 3, 4 degree of hyperextension, 5 degrees of hyperextension, get back 1, 2, 3 degrees, get them close, and then eventually it'll slowly come back. But I'm monitoring every session. I obsess my students over this. When the person comes in, they get on the table, and I measure their extension, and I look at their swelling through a sweep test. Sweep test is look at the JOSPT paper from a few years ago, or it's been a while now. So I do a sweep test. I measure their extension with a goniometer. because I want to know exactly what they're coming in at because I haven't seen them in a few visits. So I'm obsessive with it throughout the whole process. I want to know because if something goes wrong, I want to know why. Why they lose extension, or why are we losing extension? And I need to be able to track that. So I become obsessive with it.
Yeah, I 100% agree with you. Talk me a little bit through the flexion side of things. I always say, obviously it's important. I think I emphasize extension a little bit more because naturally it seems to me that, when an athlete starts, obviously when I'm doing passive stuff initially just to get it moving and kind of, patellar movements and things like that, just to increase likelihood of arthrofibrosis, swelling, all these things. But I've always noticed that, I guess anecdotally, that as the athlete starts to load more, or even squat, body weight, whatever that might be, that just flexion always comes back a little bit more easily. Is that kind of the case with you, or talk me through like your progression with the flexion side of things?
Yeah, I mean, my goals are by about 10 days, 14 days at the latest. I want 90 degrees. And so I'm trying to get it early. My doctors around here in Boston, surprisingly, they use a CPM, and I know CPM is poo-pooed by many. It helps a ton. It helps with getting their flexion back easier. They're in a ton less pain when they're coming in to see me. They are, I'm going to guess they're taking fewer narcotics. Because the parents are fearful of addiction. So they try to pull those drugs away quickly. And so it makes my life easier. I know the research does not scream CPM, but the docs in this area still use it, and it helps a lot. And again, 90 degrees by about 10 to 14 days. And then I'm slowly, once you can hit that 110 degrees, hopefully in the next week or two after that, it usually is a nice, easy process. It's that knee that has a multi-ligamentous thing. ACL, MCL, especially MCL repair, or a grade 2 MCL that had surgery too quickly, and now the MCL is scarring down, and you didn't get that prehab opportunity for things to chill and restore their motion. Those are the people that struggle, and it's a process to get their motion back. That or the meniscus repair. This drives me crazy. The meniscus repair that the doctor says 4 to 6 weeks of 90 degrees only, and then all of a sudden, all right, you can unlock it and go to town. You're like, what just happened? Like, why are we putting this restriction? I'm a proponent of motion of tolerance after meniscus repair. I did it for years when I was in Alabama. In the early 2000s, we did it. It's not a bad thing unless it's a root repair. I get it. But if it's a standard repair, a vertical longitudinal tear of the meniscus, medial or lateral, I've had no issues with motion of tolerance. And sorry, docs, I cheat. We do motion of tolerance more or less. I'm not sitting at 90 degrees. There's no way I can sit at 90 degrees for 6 weeks and think they're going to be okay and be ready to run when you say they're cleared to run at 3 months. So I have to cheat a little. And I'm monitoring pain. It's not like I'm pushing through a ton of pain. If they have pain posterior medial after medial meniscus repair, I'm not cranking it. I'm not having doing deep squats. But I think, like you said, getting them moving, getting that weight bearing aspect going helps the quads, helps things to wake up, helps the knee to calm down, and it's mentally good for the patient. You have to get them moving early.
It does. I think it helps with confidence a lot too, because
definitely.
I always say this too. There's some athletes. There's two spectrums to athletes who are coming off ACL reconstructions. You want to find someone to kind of in the middle. Most of the time, someone's ultra conservative, or they want to go.
Right.
At least initially or post-op wise, I think the ones that are a little bit more on the conservative side of things, and obviously as you get more comfortable with ACLs, you can kind of tell personality wise, like, all right, I need to teach this athlete, or versus take them back. The ones that are more conservative, I think, like what you said, just getting them moving, and even if it's passively, that improves their confidence a little bit too. Because I promise you, at home, for everyone watching out there, and you're probably aware of this, at home they're hesitant, and their parents are hesitant most likely, and then they're not doing much, and then when they come in, they're very, very stiff. So early and often, like setting the standard of like, within your best interest, we're going to move you just so you know that it's okay to do it.
Right. And remember, we're probably seeing people 2 to 3 times a week at the most. I see people twice a week, mostly right after surgery, for an hour, maybe an hour and a half session. There's a lot more hours of the day and week that they're not doing anything. So kind of why I like CPM, believe it or not. And it's only for a couple of weeks. It's not like we're doing it for 6 weeks.
What's your frequency on that? What do they like to do with that at home?
I tell them as much as you want to go to town with the CPM, but save time for ice, because it's going to help you with your pain. and save time for work on extension. So if you're doing a couple hours at a time, they're watching Netflix, they're just, taking a nap, they're whatever, perfect. Come out of it, go to the bathroom, do what you got to, grab some food, and then while you're doing that, prop your leg up, something under your ankle, and just let gravity kind of pull it down into some extension. And it works very well. I promise you. This is you have to be the leader, and you got to check on them. You can't just tell them once and then wipe your hands. That's why I'm texting people. You're doing this. You're doing that. How's it going? And then I measure when they come in to verify right away what's going on, because I can tell at home. That kid that had the pillow under his knee, he still did it that second visit. And I'm like, dude, you're killing me. We got you down to 12, lacking 12, but we still have 16 more degrees to go. Yep. And he finally gave in, because it was very painful to take that pillow away. But now he's cruising, but that leads to a cyclops lesion or issues down the road if we don't educate and stay on top of them. And so you have to. You're the professional. You have to stay on top of them and question them, and don't be afraid to question them in a nice way, but every personality is different. I like to sometimes use embarrassment. It's a 16-year-old kid. I can easily embarrass a 16-year-old kid, in front of their parents. So whatever, I don't care, but it's in a fun manner, and it works well. So you got to stay on top of it.
Yeah, I think an important thing is setting that standard early and often too. Like you said, I think, frequency wise, 2, maybe 3, especially for a high school athlete. I always set the standard of, I maybe see you for 55, 60 minutes twice a week. The other, 95% of that is everything that you're doing.
All him. Yeah.
So I want to set that standard early just because of the fact that, even 6 months out of an ACL, my job, I say this in clinic all the time, is, if it's necessary, I'll do it. My job is to not want to essentially babysit you with strength. I want to work on return to sport, mechanics, balance, whatever that might be.
Right.
You can do all that stuff on your own. It just saves time. I always say, if I could see you every single day for a week straight for 9 months, whatever it is, obviously that's a different story. But 95% of the time, I want to treat them as if they are a professional athlete, because what tends to happen is if I only see them twice and they get the impression that, a therapist is going to take care of their entire rehab for them, it doesn't set a great standard. And then, over the course of time, they're a week behind, 2 weeks behind, months behind, and then they're returning to sport. They're wondering why they're not going back at 9 months. So.
Right. I always give them credit. They always say, "Oh, Len, you did a great job with the PT, years later." No, I said, no. I just guided things. You did the work. I just gave you the advice, and you did all the work. I was just there to kind of hit the milestones and push things along and adjust as needed. But this is all you. And that's the fun part of it, because people say, you treat a lot of ACLs. Isn't that boring? No, each personality is a challenge for me.
Right.
16-year-old Tommy is different than 45-year-old Linda, who is trying to get her knee functional for her children. You know what I mean? It's a completely different world. Or 26-year-old pro, whatever. It's a completely different challenge for me, and how they respond and how I adjust to them. And that's what makes it fun. I enjoy it. Now I go home and I'm exhausted and I don't want to talk to anybody, because that's all I do all day is have to interact and talk. But I'm an introverted extrovert, I guess.
Yeah, that's what I say too.
I think it's our profession. You know what I mean? I want to help people and be well for people, but I also just want to sit in a corner and just I don't even know, just think about, I don't know, golf or something, whatever.
Absolutely.
So yeah, that's our lives, I guess.
I think an important thing that I'll talk about now too, I think it's important to, and I have this conversation with a lot of the, students or, athletes that I've worked with post-op ACL that want to come back and observe me, because that's the profession they want to go down. I think a super important aspect of maybe treating ACLs for the first time is not feeling the pressure of moving on too quickly. I think, we set a standard that it's, evidence-wise, they say the gold standard 9 months, whatever it is.
Right.
I always give that a little bit of a leeway, because I don't want them coming back in 9 months and saying it's 9 months. Why am I not?
Right.
But nonetheless, I think, and like you said, every single ACL is different. Personalities are different. Whatever it is kind of causes, the progression of the rehab to be better or worse or right along track. And I think, especially for athletes who have more difficulties getting back range of motion, swelling, whatever it might be, I think the habit, I don't want to call it a habit, but maybe something that I even felt a little bit pressure with early on was, those three low hanging fruits of, a fusion, range of motion, quad strength. If those weren't taken care of, maybe pressure from the athlete, pressure from parents, surgeon, whatever it might be, of like maybe progressing a little bit too quickly. Whereas now it's like, take a step back. If those three things aren't solidified first, we're not going to move. And I think setting that standard early kind of puts that idea in the athlete's mind of like, okay, he's right. He's not going to move forward unless I take care of this range of motion first. And I think that's where I like talking about this because, I was probably felt that same way when I first started treating ACLs, where it's like, gosh, mom's like kind of getting on me about this. The surgeon's asking why aren't they not getting to the point where they're running yet, whatever it might be. And now it's, they're not ready for it. That's simple.
They're not ready. And you have to have a rationale. You have to have your system. And for a new grad, hopefully you had, or an early career professional, you need that guidance, and that hopefully you got somebody. Mentorship's such a word that's thrown around a lot now, but like we have our students, and we know testing wise, like we have force plates, we have handheld dynamometry. It's better case, you have an isokinetic device, to test, and you need rationales, you need objective numbers, whether it's I need 120 degrees of flexion, or I need a trace of fusion, or I need 70% LSI to do blah blah blah. I try to keep that as is and stick to that because it seems to work. People can cheat a little, and you see how their knee responds, but that's why I'm obsessively early on putting it in the student's head, my head, the patient's head, the parent's head. What's their extension? What's their swelling? What's their flexion? I measure at the beginning and at the end of every session. Every session, I measure all that. And the patient turns into it's like a competition. All right, we got 92 degrees first bend. They just did all their leg raises. They did all their mini squats, whatever. We're going to do another bend. Let's beat 92. I want to get 95. And it turns into all right, keep that hip down. All right, let me push your knee. That's another thing. I bend flexion in a seated position at the edge of the table. I think it's a more comfortable position versus supine. You're standing over the person, bending their leg. Or worst case is prone, trying to bend their knee in that position, which is just basically a rectus stretch. And that is awful. So seated edge of the table, I put numerous videos in my social media about that. It's a comfortable position for everybody, and it's well tolerated. And so I do that twice every session because, again, I'm hammering home what we get early. Let's beat that, because oftentimes doing exercise helps, right? It helps them mentally, physically. Swelling goes down. Just doing leg raises, it helps. And so you get a little extra range, and they leave feeling good. Like, sweet, I just got 100 degrees. I get triple digits. Awesome. Now I want to get 110 next visit. And it turns into this positive feedback loop for them. And everybody's feeling good walking out of that room when all right, we just had an hour good session. And I'm ready for the next hour session in a couple of days, So it's unintentionally intentional in my world. A lot of what I do, and I tell my students that my interactions with people are intentional. I basically put on a show every day, and that's why I'm exhausted, because they need to feel a positive energy, right? And I have 20 plus years of data in my head to tap into what's worked for people. You have to utilize that. You can't be this ho-hum, you can show, you're showing people you don't want to be there. You're miserable. You really have to bring the energy when you're there. And I think it's critical. And then you eventually figure out your systems. And hopefully, again, you have somebody you can rely on to help you with that in the background. Yeah.
I think an important part of that you mentioned too is, the personality of the athlete too. I think that, as a therapist or PTs out there listening, whoever it is, being able to, get in the mind of, let's say, a 14-year-old female athlete versus a 21-year-old male athlete, knowing when to, like you said, even make a joke with a 14-year-old or understand a little bit more shy, but that's a super important part because, like you said, if you don't have the ability to kind of bend with the personality of the athlete a little bit, and you have kind of a straight lace or your personality stays the exact same, that's tough because it may work for some, but then you have this other population of athletes who it's like, I'm not really digging this, or I'm not really getting this personality. And then you start to see their rehab kind of take a little bit of a hit secondarily too.
I'm a good chameleon. I can adjust as needed to the personality, and I have to. You have to, and like you said, motivated 18-year-old or 17-year-old senior trying to get back to his senior year, or junior trying to get back to his senior year, who has that motivation, and they're all motivated. Trust me, it's just is there less fear? Is there more of a gung ho personality that I got to get, or I got to get it? I got to get this, next range of motion. I got to put weight on that leg versus the kind of fearful 14-year-old, 16-year-old or 20-year-old. They can be fearful as well. And you got to recognize that and build confidence in them. Or the other side is like pull back a little and let them realize, hey, if we go too fast, we can't start running at 10 weeks. It's just, even though the doctor said like, you're going to get cleared to running at 12 weeks, like we have to have a reason why. And so you have to adjust you and your personality as a chameleon. And that's the fun part. I love all that.
It is. That is the fun part of it. Cause everything else really is kind of, everything else is a little bit similar. You want to hit certain criteria objectively, whatever it is. But the fun part is kind of, the patient. It's funny that I get that all the time too, of like, treating 13, 14 ACLs on a daily basis. It's like, I get asked all the time, that's got to be the most boring thing of all time. And I'm like, it's not. It's more the personality of how, like, that's the puzzle piece for me, or like kind of the challenges, the complexity of the athlete, not only what their knee looks like, but how are they personality wise, psychologically, like how can I change to adapt to them? So
definitely.
Talk me through, so we talked a little bit about like objectives and testing. Talk me through when you guys first test and maybe what that looks like versus 6 months, 9 months, at their return to sport timeline wise.
Right. I tend to wait a little. I know some people do early. I tend to wait until about 12 weeks. Okay. Let the knee calm down, let them do a strengthening program, about 4 to 6 weeks. They're out in the gym then doing more, air squats or just some kettlebell deadlifts. Mm-hmm. So I wait. I know they're going to be weak. I don't want to, especially with a patella tendon graft, I don't need to do a max effort isokinetic test or whatever, or I don't have an isokinetic device or isometric test. So I wait about 12 weeks to get a baseline. Mm-hmm. And they've already been told they're probably not going to run anytime soon anyway. Usually, I do have somebody right now who she's a senior in college, and this is her second ACL, third knee surgery. We are on a 7-month trajectory to get her back to women's lacrosse. And so we're cutting corners, and I'm monitoring closely. We're testing. She's getting a Biodex isokinetic test tomorrow at her college, big Division I program. And we are monitoring closely. But so that's there's always an exception to the rule. Yep. But typically 12 weeks out, we're testing, getting a baseline, and they're probably going to be 60% LSI. Unless it's a quad tendon graft, and then they're going to be like 30% LSI, because I hate rehabbing quad tendon graft. Sorry, quad tendon doctors. I'm a patella tendon graft guy. I've always been, and it's just nothing has changed despite what social media has told people. And I treat quad tendon grafts, and they're not fun to treat. That can be a different story. So I just do isometric quad. I do isometric hamstring. I'm looking at limb symmetry index. I'm calculating torque based off of their isometrics. I measure length of their basically tibia. So basically lateral epicondyle down to where the strap is perpendicular to their ankle in centimeters, and get their body weight, and I measure a torque. So if they have 3 Newton meters per kilogram on their non-surgical side, and they have 2 Newton meters per kilogram, easy math, on their surgical side, they have a 67% LSI that I've calculated. And so based off of that, we will say, okay, good, this is where our baseline is, and now I need blah, blah, blah to get you to run. And it's usually, I say, around 70% LSI, give or take. If they had 67% LSI at 3 months, that would be amazing, because that's difficult. And I usually try to wait until about 4 to 5 months to start jogging. Yep. And I'll test them 6 weeks after that initial test at 12 weeks. And so that takes us to about 18 weeks, about 4.5 months, where I'm anticipating that hopefully things are improving. They sometimes don't, depending on a lot of factors. My setup testing, hopefully my testing is set up. I try to be kind of very specific in how we put people 90. I do it 90 degrees of knee flexion. Some people do 60. It's just easier to test at 90 to get that perpendicular line of pull for the isometric test. And I test about 6 weeks later, and hopefully they are breaking through that 70% barrier. And I give them the Delaware return to running program that Lynn and her group put together years ago. It's a treadmill or a track program, and it's just something that gives them guidance to begin a jogging program. And then I test every 6 weeks weeks after that, and I start adding in counter movement jumps, double leg drop vertical jump, single leg drop vertical jump. We're doing, blaze pods, agility testing. We're doing agility work in our facility. We have 11,000 square feet in Boston, so in a warehouse, so we can do agility stuff. And I'm watching them as they squat and deadlift and how they're progressing, how their knees responding. Sure. And I'm working with their, probable strength coach that they either have a champion or at their school, sure. Or personally, and putting together programs with them. And that's how it all comes together magically.
Do you, and you guys obviously have strength coaches there. Do you talk me through? So the way we do it, in our clinic, companies, we have a program very similar to, the strength coach side of things, where very similarly rehab timeline ACLs will go into a strength program and work with purely on strength, twice a week, whatever it is. I still like to see them, talk me through what your opinion on this. I still like to see them probably maybe once every other week at the most, if they're doing really well, just to check up on them. I think with some of those programs, unless it's one-on-one, it becomes a little bit difficult to kind of see mechanically if a strength coach is working with 10 athletes at a time. So I still like to see them one-on-one kind of for the duration of the rehab, or maybe once every other week, whatever it is, just to check up on it. And also probably to some degree work on a little bit more of like return to sport mechanics, some of those nuanced things that whatever the sport, caters toward, that you can still get in some of that on top of what they're doing with the strength coach. Is that fairly similar to what you guys do?
We're a little different. It's different for each patient. Some want to stay with me for the full time. Sure. And, I offer them at, whatever, 4, 6, 8 months, whatever it is for the person. I'm feeling them out, that we have our strength coaches here and they are well-versed in doing it. ACL Rehab, they're not doing ACL Rehab, they're just doing a strength and conditioning program at that point. And I'm kind of a voice in the background. Some people stay with me the whole time, and some people go to our strength coaches at 5, 6, 7 months out of surgery. And I trust my strength coaches. If they're writing a new program, they have their own testing algorithm that they do. Mm-hmm. And I will see the person once every 6 weeks to do my testing stuff. But our coaches are doing counter movement jump testing on them. They're doing drop jump testing on them. I'm probably doing more of the isometric testing. Okay. And that's my input and that's how I interact. But I trust my coaches to be able to, and they're going to come to me and say, I want to do this, this, and this. This was we just did some testing on them. This was their counter movement jump, symmetry. This was their force output. This was their jump height, or whatever we're looking at. And I just completely hand off and say, yeah, no, that's good. Or how they looking, or I'm there 4 out of 5 days a week, typically in my facility. So I tend to see it just happening live anyway. Yeah. And if I see somebody, hey, come on the table, let me do a quick check of your knee. Looks good. Awesome. And that's it. That's like just a quick check in, on the house, so to speak. Yeah, totally. And it's well appreciated, but I don't see my patients. If they go to our strength coaches, they are with our strength coaches, and I trust our strength coaches. And if they have a question, they come to me, and we're always sharing data. Sure. Yeah.
Yeah, I think that's important, the continuity of care a little bit too, because if, God forbid, you didn't trust the strength coach, that eventually to fall back on you or vice versa or whatever that is. So I think the continuity of care from like beginning to end, it's super important. Yeah. I want to talk.
And it allows the person to be able to train more. Sorry to interrupt you.
You're fine.
Because they're not going to see me 4 days a week. Training for PT. Yep. I'm cash based, and in the insurance based world, that would never work at 8 months out of surgery. But they can see our strength coach and I highly recommend. I had a kid, a 5th-year linebacker at a local college, a Division II college. We had a 9-month window, and we knew it to get him back to his 5th year in college. And at about 5-6 months out of surgery, he went to our strength coaches and spent all summer with our strength coaches coming in 4 days a week, at least 4 days a week. And you know what? He is killing it right now. I'm so proud of him that I'm watching him this fall. Yeah. And he's played since week 1. He had 9 tackles. He had all this, the fumble recovery, interception. I'm like, dude, you are killing it. And it was a close call. But, I think that 4 days a week of training all summer long and doing the agility and doing the power stuff, it was a game changer, because doing it twice a week with me was not going to be enough. And so it was a huge addition for him.
I think to go along with that too is it depends on the athlete a little bit. Some are gung ho to, they understand the strength and conditioning side and they get it and they're well aware of doing that on their own and they crush it on their own. And some people kind of goes back to the personality a little bit. Some people just
Yeah.
might need that extra push. So if you push that on them, they're like, okay, that'll keep me accountable to being here twice a
Right.
week, strength, and maybe see you
Right.
once.
Yeah. Right.
It kind of depends, like you said.
It depends, absolutely, but you have to lay out what is ideal, and
Yeah,
for that person, and oftentimes more is better. 4 days a week,
yeah,
your coaches can program 4 days a week,
yeah,
splits, two splits, or whatever, and it's going to be hugely beneficial. And so I think for somebody, early career professional, PT student, or whatever, listening to this podcast, moral of the story is develop a relationship with a strength coach that you trust in the area that you can work with, right?
mm-hmm.
You need to have that relationship, whether or not, if it's not in-house, you have it somewhere. And if it's not in-house, you should bring somebody in-house, and they learn your systems, they learn you, because it's a huge thing for you to utilize for your patient. Because again, in an insurance-based model, at 8 weeks, 12 weeks, they're done. And what happens after that? You send them to Tommy's Strength House down the street, and or Jill's Strength House down the street,
Mm-hmm.
and now they have somebody that you trust, they trust, to build programs for them. So you have to develop those relationships in the community, because they will then send you people that you want to see, because somebody in their strength world will get hurt, and they'll send it to you for PT, and it feeds this. It's a nice loop to feed into, and now you're seeing patients that you want to see, not what the front office is making you see, and you avoid burnout. Your career is better, and it's just a positive feedback loop that everybody is happy.
That's a great point. And I'm going to kind of change gears a little bit. Throughout the rehab process, I've done some research on this. I'm a huge component or proponent of it as well. A little bit more of, I always say this too, is an ACL rehab is long. And in order to, make that a little bit less monotonous, I think I try and make everything I do somewhat sport specific, or maybe not even with whatever, ball, whatever they're using, but at least to the point where maybe after the initial stages of getting quad activation, things like this, where they're doing something a little bit more sport specific. And what I mean by that is either like multitasking or something that has to do with an external focus of attention, anything like that, that I can get them to more or less think. I always make the case that whatever sport you're going back to, especially level one sports, your goal is to get back to the point where you're not thinking about your knee, and it needs to be very automatic. So as much as I can do, even if whether it's 4 to 6, weeks out of an ACL, where they're doing something as simple as side steps with a band, at the same time of, tossing a ball at them, or, if they're a soccer player, whatever it is, having them do a, roll back to me, something like that, to where they're not thinking about their knee. And I think through the course of the rehab, when you get to 6 to 9 months, whatever it is, where they're actually doing something high level, their thought process is much quicker, because they're thinking away from what's going on at the knee. Then they can focus on, I always use like go back to soccer, for example, because I was a soccer player. You have the crowd to deal with, you have other players, you have your teammates, you have where's the ball going to be. I don't want you focusing on the mechanics of how you're landing. Let's say you go for a corner and a header. I don't want you thinking, how am I going to land this like I would in clinic? Because that's very regimented and rigid. I want it to be, what's next, or how can I control the situation, what the next play is, not thinking so, in tune with what's going on. So
that's what a lot of the research is screaming at us, is all of Meredith Chaput and Dustin Grooms and anybody else that's doing all the neurocognitive research. That's huge, and it's rewiring the brain. And I think it makes them feel more sporty when you're throwing a basketball at them doing lateral band walks. Lateral band walks, great, fine. You're working to get a nice hip burn. They feel it, awesome. But you know what? They feel really good when they're getting a basketball thrown at them. Because it feels sporty, and they actually feel like an athlete again, and not this limping, incompetent ex-athlete that they're feeling like. They want to feel athletic again. So it's a great way. You're bouncing the ball at them, you're talking to them, they're doing a math problem, whatever you can do to get their mind to not think about, stay out of valgus when I'm squatting, or, using a mirror, something like that. And I think it's just challenging their body and let their body figure it out. And you give them some feedback, but they're executing, and it's a huge component. And some of our research is starting to show that we're seeing. It's pretty neat to see. Yeah.
It's pretty interesting research. Last couple things, then I'll let you out of here. Talk me through more or less the importance of like psychological readiness to play or return to play. There's evidence is kind of showing two sides of the spectrum. Someone who is overly cautious, maybe has a
Right.
slightly higher risk, and then someone who is, borderline, I don't want to say cocky, but someone who is like not even questioning whether or not they're ready to go.
Who
Talk me
also has a
through,
slightly higher risk, right? Some of the
yeah,
research you're saying, if they come back too quickly, despite they pass their tests,
yep.
they have a higher risk of ACL tear. So, and I think again, going back to our conversation, that's the fun part of what I do is
Hmm.
recognizing that. And the people that are cocky, I have to address it appropriately, whether I have to pull back a little or show that they're not ready, or maybe I'm talking about some research or whatever, and not in a nerdy way, but just like,
Yep.
we got time. Like, even let's get you on the field, let's get you with your athletic trainer at school or strength coach or somebody, and do some stuff. And the other side, the flip side, that person, the 16-year-old who's fearful, I'm using sparingly, and sorry people, I don't do a lot of ACL RSI testing or Tampa scale stuff,
Sure.
but in the person that is fearful, I will, so I can monitor them and they can read the questions that that are applying to them and their function and their how confident they are in their knee, and I can track that. And if their RSI skills are improving over time, great, like that,
Yeah.
that means they're going in a good direction. But if they start dropping off, then that's an issue. I don't use them a lot. My 16, 17-year-old junior who's trying to play next season, he is not that fearful. He is trying to push things and trying to, at least in my world.
Hmm.
It doesn't mean everybody's world is like that. So my RSI, when I've given RSIs in the past, when I became all gung ho to use, all this testing, I was like, dude, are you really like 90, whatever, 92 score? Like, come on, you know? So that's why I stopped. But once I start recognizing that, a 15-year-old, shyer patient,
Yeah.
oftentimes female, unfortunately,
Yep.
in my opinion, they have a tougher time getting back muscle. It's that
For sure.
18-year-old male is like raging testosterone. Like
Right.
he
Oh,
is,
totally.
it's like BFR all day long
It
and
is.
naturally in his body,
It is.
and that 14, 15-year-old female, 16-year-old female,
Yeah.
to me, it's a more of a struggle. So BFR is probably going to be more appropriate, and talking them through it is going to be more appropriate, and RSI scale for me. But again, I also have that 15-year-old female who cruises and is doing awesome. But you're going to just figure out which one you're dealing with and work appropriately. So there is that component, but from day one, I am building confidence because I know
Sure.
that the psychological component is going to be an issue down the road. So I'm building confidence. Like, great job. Look at that squat. Put them on a fourth plate. You look at your symmetry. It's a ton better than last week. I'm always, again, it goes back to me putting on a show all day, every day
Yeah.
for these patients because I need to build. They have to leave feeling positive in that session. Even if the session was a sucky session, they still felt somewhat positive about something, and I'm going to focus on that positive for them.
I think a big part of the psychological readiness, in my opinion, is I always say I want to bridge the gap between like the rehab side of things and then a return to the field or wherever you're going. So if I can incorporate confidence with, I always go back to the sport, right? Because every single nuance of a sport is completely different, whether it's you're going back to baseball versus you're going back to a contact sport like football, right? So if I can build little things throughout the program, obviously appropriately versus the timeline wise,
Right.
to the point when they get back, they're like, oh, I did that 6 months ago or whatever it is,
Right.
where all these little things just start to compound in their head that over
Right.
the course of time, subconsciously, they're like, oh, that's not a problem. Because a lot of
Right.
times you get like 9 months through it, maybe, at certain clinics, like you said, they haven't even touched a ball. So then they go
Right.
from 9 months clearance points and then they're back on the field and like, I haven't touched it
Right.
in 9 months. What am I
Right.
supposed to do?
Right.
So
Right.
I
Yeah.
think, like you
No,
said,
definitely.
incorporating the confidence with little things throughout the rehab process
Yeah.
is super important.
Yeah. Definitely. You have to.
Last thing I want to talk about, and I'll let you out of here. We talk a little bit about, I think, objective criteria in the research nowadays is we're trying to push it. We're trying to go after it of like, this is the right, series of tests that we want to complete that
Right.
the athlete needs to go through to kind of go to more of like the subjective side of things. I think in my approach, obviously objectivity is important because you want the data to be there. But
Right.
even, let's use a hop test, for example, because I like using that as a kind of pick on the hop test a little bit. If you're athletic enough, you can cheat a hop test. So numbers may be deceiving a little bit, in my opinion, when it comes to these types of things. So I think in the mind of a physical therapist, from a subjective standpoint, let's say you don't have, we have 3D motion capture in labs and things like that where we can measure angles of the knee, hip, ankle, whatever it is, because that gives you a little bit more of like a objective, subjective of like what that knee looks like when they're hopping. But
Right.
some clinics don't, a lot of clinics don't. So I
Right.
think having, the training of a PT who understands movement of what an athlete has to go through, whether it's soccer, football, basketball, baseball, whatever it is, the nuances of that sport. So a little bit more of like the subjective side, because I think some PTs can get a little bit away from, oh, they cleared 90 strength wise, hop testing, they're good to go. It could be a completely different story. Like I've had an athlete who is athletic enough to probably cheat a hop test, but I promise you they look terrible doing it. And
Right.
then in my eyes, I'm like, oh, they're not even close. But a surgeon sees that or another PT may see that and be like, all right, they're good.
Right. And I explain that strategy to them like that. I'm just open with them that
Yeah.
we're doing these tests. You can use your glutes a lot. You can use,
Yeah.
the other muscles, and I need to focus on your quads. Are king, right? Quads are the money maker essentially when you're coming back from an ACL. So I explain that to them that look, you did a great job. You stuck it. And for the record, I don't do hop tests, so I just don't even have to have the conversation with people. But I'm doing vertical jump tests and drop jump tests, and I'm doing kind of movement jumps, and I'm having them jump. And I'm randomly, everybody has a phone, right? So everybody has an iPhone, so you can record people, and I'm always doing that, recording people doing jumps and showing them, like, look at this position compared to the other side, and like, oh yeah, look at that, and so you can see, and all right, we give cues to feed, to give, to correct, or it just happens over time. Once they get stronger, they don't use, whatever movements, it corrects itself, and so I'm constantly recording stuff on my phone and throw some on social media or not, but just for other people for educational stuff. But I'm constantly doing that and let them see, all right, you just did a set of 10 or what 8. Like, look at this was a couple of the reps in that set. Okay, good. Next set, let's work on blah, 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 getting this feel of, are you pushing your knees out? Are you landing more, land quietly, land softly, lands on the balls of your feet? You're landing, too much on your toes, and you give all those cues and feedback along with all your testing that you're doing, and along with looking at their extension and looking at their swelling and talking to the parents and talking to them and talking to anybody else that's involved in their rehab process. And that's the full picture of what comes together. It's not just, they have a 90% LSI and their kind of movement jump is, perfectly symmetrical and they're jumping 20 inches plus. There's so much more that's involved. And those are the small steps that you have to utilize along the process. Again, everybody has a phone. Use the slow-mo capture on your phone, and you can gather so much information from that and give immediate feedback to them. So it's an easy way to, to show that they are not where they need to be, and to give feedback to show them where they need to be.
Right. Yeah. Great point. Because you can always do the contralateral side and show them this is what, this is what it looks like. Last question I have for you, for those who are considering going down the physical therapy route, specifically the sports performance side, and maybe even a little bit more specific, going down the working with, like maybe us, where we work with ACLs all day, every day. Talk me through, a little bit of like maybe what you tell your students of this is what you need to be doing, mentorship, whatever that might be, to kind of sets you up for the most success of when you start practicing and maybe getting to the point where you're treating these ACLs for the first time on your own with a full caseload, that transition is just a little bit, I don't want to say easier, but it's a little bit more, like you get it a little bit more, that you kind of understand what's going on, how to work with them, and kind of go from there.
Yeah, I mean, you're going to be winging it for the first 6 months easily. So hopefully you have people you can fall back on. I've spoken to numerous people. People DM me. I try to check my DMs on Instagram or Twitter or something like that. I'm very active. If people have questions, by all means, I'm here. And I had people in my life that helped me early on, and I'm still learning stuff. So it's always a constant learn. So don't think that you are inept and you don't know what you're doing. You know more than you think. It's just having the confidence to put into practice. But read the research, like read some of these papers that are coming out on neurocognitive stuff and return to sport testing and go to conferences and have relationships with the doctors that are in your area, and shadow them and go see their surgeries, or go with a patient to their follow-up appointment and just listen to the doctor. I've done that, and it was a huge advantage when I first moved to Boston to get confidence from doctors. Like I said earlier, strength coaches and other ancillary people, pitching coaches. I deal with baseball and ACL. There's not a common one, but still, it happens. I got a guy right now. So when to stop pitching? You're not a pitching coach. You don't have to be a strength coach, pitching coach, PT, psychologist. You don't have to be all that. You have people to work with in your area. So develop those relationships. It's huge to have that. And so, you have to have all that and utilize social media and utilize PubMed. And it'll eventually all come. And it's practice. We practice medicine, so to speak, right? Like doctors are practicing medicine. We practice as we go, and we learn as we go. So have all these mental check marks in your head of what's worked, what hasn't worked, and you eventually refine your craft, and then you're good after about a year or so. You're better. You're not good. You're better. You feel more confident.
Exactly.
Yeah.
Well, I appreciate that. That was fantastic. I think it's important to kind of see all sides of it from, like you said, seeing what the athlete looks like when they get injured, what their knee looks like, and then, having that conversation with the surgeon, seeing what the actual ACL reconstruction looks like, I think is important to kind of understand how it should be rehabbed afterwards. And like, with you, Lenny, talking through kind of the rehab side of things, I think getting into a little bit more depth of maybe the ACL and, some of these later talks or bringing you back on would be kind of a cool thing to do. But I think setting the standard with the psychological portion of this, all these little basic things that physical therapists can kind of really solidify throughout their practice, I think is very important. So I appreciate you coming on. It's been fantastic.
Thank you. Thank you for having me. And like I said earlier, I'm all over social media. So if anybody has any questions, I'm always happy to chime in, and I always have an opinion, it seems. So you can find me on Twitter, now X, or Instagram at LenMacPT.
Very good.
And I am available for you guys. So we work better as a team, right? So let's try to accomplish this thing as all friends and work through it. Yep.
I appreciate it.
Thanks for watching. If you're a physical therapist or other medical professional looking to elevate your ACL rehab practice, visit tornuniversity.com and book a one-on-one consultation where you can speak with me directly about any specific challenges you may face and fine-tune your approach to ACLs. Also, be sure to check out my monthly webinar series where I dive deeper into ACL-related topics designed and shaped by your specific needs and questions. Don't forget to like, subscribe, hit that notification button for more content, interviews, and more. Follow me on social media at Torn University for more daily ACL-related topics. And as always, drop any comments or questions you may have about ACLs, and I'll catch you guys in the next video.